Good morning, everyone. Good morning, dear patient, dear colleague, and dear friend. Now we will start with the next lecture. I think it's no need for me to present myself. I'm Professor Possover. I'm the chairman of the International Society of Neuropelveology. I founded the Society of Neuropelveology. And once again, I believe very, very strongly in patient education. And I want to bring you some knowledge in neuropelveology. And today we'll have a lecture on something normally that don't exist. It don't exist, and that is what we call here pelvic pain after prolapse repair. So I will have this lecture as a complication of what we call mesh rectopexy and sacrocolpopexy. So I will report here about a series of 38 patients. It seemed to not be a lot of patients. But if you take a look on the literature, you go on PubMed and you check a little bit, how many publications you will find on complication of nerve complication after sacrocolpopexy. Sacrocolpopexy, woman after hysterectomy, prolapse of the vagina, and you fix the vagina to the os sacrum with a mesh, and rectopexy, men and women with a prolapse of the rectum, and you fix the rectum to the promontorium of the sacrum, the bone, the spinal bone, with a mesh. If you check the literature to try to find paper on such nerve complication, you will find nothing. So it means that these complications don't exist. And that is not really what I see in the neuropelveology. I see patients with complication, nerve complication, neurologic complication after such kind of prolapse surgery with the use of a mesh. And that means 38 patients that are patients I collect over more or less the last 15, 20 years. So it's very seldom. It's very rare. But for the patient who is affected by this issue, it's really a lot of pain. And once again, the main problem is that she will have a lot of difficulty to find somebody who can help her because this pathology seems to not exist. So, what is a sacropexy? Sacropexy, it's usually a surgery, mostly performed by laparoscopy on robotic surgery to treat pelvic organ prolapse. So, it's used sacrocolporectopexy in women when the vagina is falling down. We will fix the vagina, but because the vagina is too short to fix the vagina or the sacrum, then we have to bring a piece of mesh in between. And rectopexy is exactly the same. And visceral surgeon very often combine the rectopexy with a resection of part of the bowel. The main difference between both procedures is that the sacropexy performed by gynecologists, also the colposacropexy for vaginal prolapse, is usually performed only on the right side, while rectopexy performed by general surgeon are performed on the left and on the right side. So it made a difference in terms of which location of the pain. So, and what can go wrong is simple. Out of the sacral bone, you have the sacral nerve roots coming from the spinal cord. They emerge through the sacrum, will fusion together and will build together the sciatic nerve, the pudendal nerve, and what we call the pelvic splanchnic nerve. That means the nerve involved in the voiding function of the bladder on the rectum, and the nerve in men involved in the erection. So if you put a mesh, you have the risk to have a primary lesion. You put the mesh with a suture directly on the nerve, or you have the risk of secondary injury. You put the mesh or your suture close to the nerve, and over time, because of the mesh and the suture, the body will develop some scar tissue, and at some point, the scar tissue will reach the nerve and will start to induce an irritation of the nerve. So The typical symptom of such kind of sacral radiculopathy, that is a nerve lesion, the sacral nerve lesion after sacropexy, are first anogenital pain, and the main nerves affected by an sacropexy on the left and on the right is the second one. And the sacral nerve root number 2 is usually more in charge for the anus. So patient can develop some anogenital pain, but burning pain, but mainly the anus area, gluteal, that is the buttock, and it's typical when you perform a sacropexy. Most of the patient will feel some pain in the buttock, but when the pain is too much, when a patient report, I have a pain from 8, 9 on a scale from 10, and first of all, if this pain don't decrease after a few hours or over the coming 2, 3 days after the surgery, then something is wrong. So the pain can be located as well in the lower back, and we're talking from neuropathic pain. That means burning pain, pressure pain, tingling, electrical shock, with radiation down to the leg, the dorsal upset to the leg, even down to the foot. If we're talking from a primary lesion, that means you have a damage of the nerve. It's not just an irritation of the nerve because the mesh is close to the nerve, but maybe you fix the mesh on the nerve, then the patient will develop numbness, and not just burning pain, tingling, but numbness in the same area where they feel the burning pain. And of course, that is for the sensory. But this nerve contain also motor nerve, and the motor nerve for the leg, so the patient will feel weakness, will develop some difficulty for walking, and she will also develop some difficulty with bowel function and with bladder emptying. All these symptoms mixed together are typical for a sacral radiculopathy. Now, the gender distribution, you see much more patient, a woman than men. Yeah, because in our study, I'm a gynecologist. I'm not just a neuropel, I'm a gynecologist. So most of my patients are women. And women, what I mentioned, the sacrocolpopexy is performed on the right. So it will the patient will mainly develop pain on the right. Now, if it's after rectopexy, and in rectopexy you will find men and women, it's much less, but the pain will be sometime on the left, sometime on the right, or sometime on both sides, depending from where the surgeon fixed the mesh on the sacrum. So once again, tip on radiculopathy, I already mentioned the primary versus the secondary lesion. So the main question during the neuropelveological workup is, when did you develop the pain? If you start to develop the pain months or years later, it means the colleague performed a good job, he fixed the mesh on the sacrum, but over time your body develop scar tissue, and at some point this scar tissue reach the nerve and will induce an irritation. That is, by the way, the best situation. The second is a primary lesion, and that is usually the most difficult to treat. Is when a colleague performs a surgery, you open the eyes directly after the surgery and you say, wow, I feel such burning pain, such increasing pain, huge pain in my buttock, eventually going down. Then probably the colleague brought the mesh or the suture or sometimes some screw close to the nerve. And if you have weakness, numbness, difficulty to move your leg, probably directly on the nerve. So, and that will make the differentiation if you're suffering from a neurogenic or a non-neurogenic. Non-neurogenic is likely secondary lesion, so there is no damage of the nerve, there is only an irritation of the nerve, or maybe a compression of the nerve by scar tissue, or maybe by the nerves. While neurogenic means you have damage, you have nerve damage, because the mesh, the suture, the screw were put directly on the nerve with neurological disorder, weakness, numbness, gait difficulty. So the main problem why I mentioned that you will find no publication of such kind of a complication is because first nobody want to report officially with publication of own complication. Secondly, if the pain develop months or years later and secondary sacral radiculopathy after mesh prolapse surgery can also occur 20, 30 years later. So if you're coming to a doctor, I have sciatic pain 30 years, 20 years after sacropexy, nobody will think it could be linked to this procedure 20 years later before. And of course, if you're going to your GP with some lower back pain and sciatic pain, of course, everybody will say you have a spinal disc issue, so you will undergo any discus hernia surgery, or some orthopedists will fix a piece of metal in your back. That is a typical misdiagnosis. Now, depending from who you will consult, if you go to a physiotherapist or osteopath, maybe they will, especially in secondary lesions, they will tell you that you are suffering from myofascial pain or a piriformis syndrome. And of course, the piriformis syndrome is directly behind the nerve. But once again, a muscle don't bring the information of pain to the brain. The nerve are doing that. Now, if you develop the pain directly after the surgery, and suppose you have not that neurological disorder, probably you will get the answer, no, it's normal after the surgery that you have pain in your buttock and your leg because it was a surgery. I fix a mesh of the sacrum, so go home and you will see the pain will disappear in the coming few days or few months. And if you see the pain are not disappearing, probably it's not normal, it's probably a complication. And the problem is always, like always in neuropelveology, if you develop a pain and nobody is able to make a diagnosis to bring a name on your pain, it's easy to say that your pain is your brain, what we call psychosomatic. And that is really a big mistake because it's not true. If you have really a nerve issue, you have to treat the cause and not to treat the symptom. And of course, if you are in the corner psychosomatic, you will get a lot of psychosomatic treatment with antidepressive, and at some point, all this medication will reduce the awareness of your brain to feel the pain, and maybe you will have less pain. But the pain will never disappear as long as you don't treat the cause of the pain. And my experience with pain treatment of the symptom pain is over the time you will have to increase slowly but surely the doses of painkiller. And all painkiller first are not focusing just on the nerve that brings the information of pain to the brain, but or the nerve from the whole body. So you will get a lot of side effect, mouth dryness, you will have difficulty with to see, you will have a loss of concentration, your partner will have to answer 3 times the same question until you will give an answer. And of course, the antidepressive and the painkiller will decrease the activity of the bladder and the rectum, so you have the risk to develop one bladder infection of the neck, etc. So the key in neuropelveology is first to recognize it could be a nerve issue. And if you see that it's burning, it's going down in your leg, and nobody can help you, probably it's a neuropelveological diagnosis. Neuropelveology is typical. I see that I'm doing neuropelveology since 20, 25 years. Most of the patients are coming here with, I have a pain and nobody know what I have because I have orthopedic pain with lower back pain, I have sciatic pain, neurosurgery, neurology, I have issue with my bladder, it's urology, I have problem with my anus, that is a coloproctologist who will find a fistula or some hemorrhoid, and maybe I have some issue with a vulva, and the gynecologist will tell me that I have any vulvitis infection, something like that, but no any treatment was able to help me. That is typical for neuropelveology. So, and neuropelveology, the key is a diagnosis. You have to know before you do anything, it's a neurogenic or it's not a non-neurogenic. Because if it's a compression of a nerve, you have to release the nerve. If there is a cutting of the nerve, to perform a surgery and to release the nerve will not help. And that's the reason why the treatment will depend mainly from neurogenic or non-neurogenic. And if it's non-neurogenic, just a compression, irritation of the nerve, the treatment of choice is a nerve decompression. You release the nerve. While when you have a cutting of a nerve, to decompress a nerve, to say hello to a nerve, will not improve your pain. If there is a lesion, a damage, a cutting of the nerve, the treatment of choice is what we call neuromodulation. You have to bring electricity on the nerve. And for that, you have two possibilities. The sacral neuromodulation, if it's possible to bring a lead electrode to the nerve coming from behind, from the sacrum, or the procedure I have developed for 20 years, the Lion procedure, means the laparoscopic implantation of neuroprothesis to the nerve. That means you use a laparoscopy to bring a stimulation lead electrode to the injured nerve. This electrode is connected to a pacemaker, and the pacemaker will bring electricity on the nerve that will cover the information of pain. So in Lion procedure, you don't treat the cutting of the nerve, and mostly if you see the patient months or years later, you cannot reconnect the nerve, because if you see one of my lecture on nerve injury, once you cut a nerve, the distal part, the part below the pelvis, will completely disappear. And then if you try to perform a reconnection, you will find one piece, but you will not find a second piece. So now the results are not the same, whether you're suffering from a neurogenic or non-neurogenic. When you have a non-neurogenic, is here on the left. The non-neurogenic, you will release the nerve, and then you have more or less 75% chance to get a pain reduction more than 50% in the coming 6 months to 1 year after the nerve release. Never disparition of the pain, because one part of your pain is always the central sensitization of the pain memory. The results for the neurogenic lesion after cutting of the nerve are not that good. You can have an improvement of the pain with the neuromodulation, but to say more than 50% of 75% of the patient depend from the intensity, the damage of the nerve. It is a fully cutting of the nerve, or just a burning, for example, of the nerve, or if it was a stick passing through a nerve and you can remove it. So in neurogenic, the key to improve the results is how fast you will react. So suppose you underwent a sacropexy, and you mentioned the day after, I have huge pain. If you go 1-2 days after, you cut the suture and you release the nerve, even in some neurogenic, it will be much better for you. You have much better chance to recover a normal life without pain. If you do that months, years later, the longer you will wait, the more difficult it will be, the more it will be tricky for you to get less pain. And the more you will wait, the more pain memory you will develop over time. Now, there is a very, very important information, and that's the reason why I show you the two pictures on the left. So, in the mind of gynecologists, you perform a fixation of the vagina or the rectum with a mesh, and the patient develops the pain. So, the cause is the mesh. So, the logical reaction is to say, let's go and remove the mesh. So, if you got a mesh implantation because of a prolapse and you remove the mesh, you have a high risk to get a recurrence of your prolapse. Your vagina will fall down again, the rectum will go down again. Secondly, from the neuropelveological point of view, to simply think, do you think that the mesh is able to bring the information of pain to the brain? No. The mesh is not linked to the brain. The nerve is linked to the brain. So if you see on this picture here, I had a patient with a fixation of a mesh to the sacrum. In blue here, you see the stitch that the surgeon used to fix the mesh of the sacrum. And what I did, I released the nerve. I didn't even remove the suture. I didn't remove the mesh because the key treatment is to release the nerve. And to remove the mesh will make your surgery even much more difficult. You will develop much more scar tissue, which can in turn produce the next entrapment of the nerve. And secondly, when you have a mesh, the mesh are very close to the rectum, and you have always a risk to get a bowel injury. So don't remove the mesh. In most cases, it's no need. That is not the treatment of choice. The treatment is the release of the nerve. And here you see in the picture above that is really not easy to perform such kind of surgery. In this patient, a colleague fixed the mesh on the sacrum, directly on the nerve, with a screw, a piece of metal. So I had to remove the screw from the bone, and that is not easy. And then I release the nerve. But once again, I didn't remove the mesh. I removed the screw because screw can induce a lesion of the bowel or lesion of some vessel on the ureter. But I didn't remove the mesh, and I fixed during the procedure the mesh on another place away from the nerve with a stitch in order to not induce, because of my surgery, a recurrence of the prolapse. So such kind of surgery have nothing to do with gynecology. It's not an endometrial surgery. It's not an hysterectomy. It's not a surgery for an ovarian cyst. It's a neurosurgery performed by laparoscopy in the pelvis. And because of the scar tissue, it's very, very easy to cut the nerve, to induce damage of the nerve while you try to release the nerve. And that is exactly what have not to happen. So in such kind of surgery, you need a neuropelveologist. You need somebody who exactly know where to find the nerve. And the way is not to jam on the scar tissue, the stitch or the mesh, but to try to find the nerve in normal anatomical condition away from the scar tissue, and then you follow the nerve and release the nerve. And once again, that requires years of experience in laparoscopic pelvic neurosurgery, or what we call laparoscopic neuropelveology. So, the key takeaway for you, patient, sacral radiculopathy after mesh prolapse surgery is rare, it's true, but exists, definitively exists, and can be treated. The second key information is early diagnosis is a key if we are talking of pain reduction after the treatment. So you got a promoter fixation, sacropexy, that you have some pain, it's normal. But if you see after 2-3 days, the pain is not decreasing. The pain is even increasing. And if you feel some numbness, some weakness, then you have to call your surgeon and tell, could be a lesion of the sacral nerve root during the sacropexy. And you have to tell that the surgeon, because a lot of gynecologists are not aware on the nerve in the pelvis. And if you need a treatment, you need a clear diagnosis, because you cannot go there and say, I will dissect all the nerve. Based on the neuropelveological diagnosis, the surgeon will know exactly which nerve. If you have a lesion, a compression of the sacral nerve root S2, you have to release S2, and not S3 or S1, but S2. And for that, you need a clear neuropelveological diagnosis. And the better the diagnosis, better will be the final results in terms of pain improvement. So specialized care in neuropelveology definitively improve the outcome, definitively. So, thank you very much once again for your attention. I want to bring this knowledge in neuropelveology to the patient and, of course, to the doctor, to my colleague, because to have the best management of an issue is to have a perfect symbiosis between the patient and the doctor who have to speak the same language. So once again, I thank you very much for your attention. Keep healthy and see you in some time for the next video of my channel YouTube. By the way, here you will see www.possoverneuropelveology.com. It's not for the patient, but there is a clear platform and system provided by the International Society of Neuropelveology for education and certification in neuropelveology. And for such kind of diagnosis, and first of all, surgery, you will need a neuropelveologist ISO certified level 3. There are 3 level 1, 2, 3. And for such kind of difficult procedure, you definitively need a level 3. Have a good afternoon. Bye bye.